Thank you very much for the introduction. Hi, I'm Michelle Maurerman, and I have the task of trying to talk about peripheral neuropathy in 1 hour. So it's going to be a little bit challenging, but hopefully we can cover some of the most valuable information and a general kind of approach to peripheral neuropathy to make these patients a little less complex and a little more streamlined in how we handle it in the clinic, and kind of know what kind of test to order in each type of situation and when to refer on for help if needed. These are my disclosures. So just to take a step back, the first thing in peripheral neuropathy is just making sure, obviously, we have a localization to the peripheral nervous system. So sometimes it's challenging, and we see quite a few patients in our clinic that actually have more of a central nervous system localization when we do our examination. And so patients who present with weakness or sensory loss, it's important to make sure that the reflexes tend to be diminished in the affected limb rather than seeing signs of upper motor neuron involvement like brisk reflexes or increased tone in the affected limbs. We also typically do not see a hemi-body localization and peripheral nerve involvement. It's more of limbs affected, mostly the legs, followed by the hands. Usually we also see sensory loss more in hands and feet, but sparing the trunk. Typically, small fiber involvement, such as pain and temperature, and vibration and proprioception loss are also affected on the same limb rather than seeing cross signs, which would be more consistent with the spinal cord localization. Also, one thing that's helpful is determining whether or not the localization is focal. So knowing whether or not the sensory and motor signs are localized to a single named nervous system structure. So what I'm really trying to say is that we're trying to differentiate nerve involvement rather than root. One of the things that's sometimes difficult to distinguish is lumbar radiculopathy and peripheral neuropathy. So really trying to see if the findings localize more to one spinal root. It's also helpful to know whether or not symptoms localize to a region like the plexus, like in a brachial plexopathy, or simply trying to exclude a mononeuropathy, typically an entrapment mononeuropathy like carpal tunnel syndrome or ulnar neuropathy at the elbow or fibular neuropathy at the fibular head. And when we're not sure, nerve conduction studies EMG can really help and differentiate peripheral neuropathy from these other conditions. Just so we're on the same page in terms of nomenclature as well, we want to think about the anatomy of the peripheral nerve, and that helps us kind of think about the types of neuropathy we're talking about. So most neuropathies involve the axon itself. So it's kind of a dying back neuropathy from the distal nerve endings. But some neuropathies really involve the myelin sheath and are more of what we call a demyelinating neuropathy. We also want to think about which types of nerve fibers are involved again. And so just to kind of review, we have our large myelinated fibers, which do motor and large fiber sensation like vibration and position. We have our small myelinated fibers that do some pain as well as temperature, and our unmyelinated fibers, which are pain and autonomic. So why do we spend time talking about peripheral neuropathy? Well, as you know, probably from your practices, peripheral neuropathy, as well as neuropathic pain, are some of the most common complaints that we see in the neurology clinic. So it's really important that we can assess these patients efficiently and get them to the right evaluations as quickly as possible. And just another kind of sense about the scope of the problem is peripheral neuropathy is, again, super common. In the population, it's 2 to 3%, and that increases to as high as 8% in those over 55. When we looked at our Olmsted County population, we saw that increased even higher when we get into the 70s to 80s years of age, especially in men. And the evaluation of the etiology of neuropathy is important. We couldn't define treatments that can prevent progression to disability for some of these patients. So what I want to work through today is an algorithm that I use in the clinic to approach peripheral neuropathy patients, and I hope that you'll find it helpful. So we're going to break it down into 4 questions. The first is what? So this just talks about which nerve fibers are involved. Then we'll talk about the where, or the distribution of the nerve involvement. The when, which is the onset and the type of progression of the neuropathy. And the why, which is clues from the patient in terms of their past medical history, social history, family history, that helps us identify what may be possible etiologic causes. So just when to worry about a neuropathy, when to maybe refer it on for further evaluation, are those patients who have a really acute or subacute onset. It's very progressive and severely functionally limiting. And that can be independent of the type of pattern of neuropathy, like if it's length dependent or not, or the modalities that's involved. We also want to think about those patients who are non-length dependent. Maybe they have proximal and distal involvement of the nerves, or it's really multifocal and patchy, or those that are really motor predominant or have severe autonomic dysfunction. Those can be signs of more worrisome types of neuropathy, or potentially treatable, that we don't want to miss, and we want to get on that evaluation quickly. So let's start with our 4 questions when we approach neuropathy, and those are going to help us split these types of neuropathies into those that are more likely inherited and those that are acquired. And amongst those that are acquired, we're going to be thinking about those that are more metabolic, immune, neoplastic, or infectious. So let's first talk about the what. So these are what sensory nerve fibers are involved. So first, we're thinking about sensation. So we like to think about these in terms of what causes positive neuropathic sensory symptoms. Those are the ones that shouldn't be there, like prickling, tingling, sharp, shock pain, sensitivity to touch, allodynia, burning, or freezing types of symptoms. Versus those are a negative or a lack of feeling. So patients might describe just deadness, or like their foot is wrapped in saran wrap, or they have a sock on when they don't, or they're just imbalanced, especially when their eyes are closed. So we spend sometimes too much time on the sensory exam. It's still subjective, and we don't want to get too micro in terms of the way that we're assessing sensation. So typically what we do is test sensation at the toe and the fingertip for the different modalities: light touch, pin, temperature, vibration, and proprioception. Just determine whether or not they're normal or abnormal, and then try to find the proximal extent of the abnormality. So how far up the abnormalities extend on the limb. And just a pearl is if there are